everyone, today we are going to cover ulcerative colitis, so let's get started. So what is it? Ulcerative colitis is an inflammatory bowel disease that causes chronic inflammation of the colon. So the key features are that it always starts in the rectum and extends continuously upward toward the colon, so no skip lesions. That's what separates it from the Crohn's disease. So the inflammation is superficial and affects only the mucosal layer. So how do patients present? There are classic symptoms like bloody diarrhea, which is the hallmark symptoms, and patients see blood and mucus with frequent bowel movement. Second, there will be abdominal cramping pain in the lower abdomen. Third, fecal urgency or tenesmus, which is an intense urge to go that can happen 10 to 20 times per day. This severely affects quality of life, so you'll also see weight loss and fatigue. So how do we diagnose it? So we start with labs. We check for inflammatory markers where ESR and CRP are elevated, and fecal calprotectin is very useful, so it's significantly elevated in this case and helps distinguish IBD from IBS. So Bianca antibodies are positive in 60 to 70% of cases, but that's just suggestive. So the gold standard is colonoscopy with biopsy. So we look for loss of the normal vascular pattern and friable mucosa that bleeds easily when touched, and erosions and ulcerations. The inflammation starts in the rectum and extends continuously, so no skip areas. So we always biopsy to confirm the diagnosis and rule out other conditions. So treatment follows a step-up ladder based on severity. So for mild to moderate disease, it starts with nicotinamide. So this is first line. So the route matters. For distal disease, we use rectal suppositories or enemas. For extensive disease, we use oral formulations. So if that fails, we step up to corticosteroids like prednisone. And these work fast for acute flares, but are only for short-term use, so never for maintenance due to side effects. So for steroids-dependent or refractory cases, we use immunosuppressants like azathioprine. So for severe diseases, we have biologics like anti-TNF, tumor necrotic factors, drugs like infliximab, vedolizumab, or JAK inhibitors like tofacitinib. So if medical therapy fails, surgery is the final option. So there's two categories of complications. Acute emergencies include toxic megacolon, where the colon dilates beyond 6 centimeters and can perforate. So massive GI bleeding and perforation itself. And these need immediate intervention. The major chronic complication is colorectal cancer, and risk increase after 8 to 10 years of disease, specifically with the extensive colitis. So this is why surveillance colonoscopy every 1 to 3 years is essential. We are looking for dysplasia, and here is what's unique about ulcerative colitis, because surgery is curative, so total proctocolectomy removes the colon and rectum, so completely curing the disease. So when do we operate? 5 main indications: dysplasia and or cancer on surveillance, and toxic megacolon, perforation, massive bleeding that won't stop, and refractory disease when medications fail. Most patients get an ileal patch anal anastomosis to maintain continence. So that's it for ulcerative colitis. It's a continuous inflammation from the rectum, bloody diarrhea as the hallmark, and colonoscopy for diagnosis. Step-up treatment with mesalamine first, and surgery is curative. So if you find this useful, please share, like, subscribe, and drop question below. See you next time. Bye-bye.